I think it is that the top of the hour, and we are going to get started. So I'd like to start by thank you for joining us again for another Florida Medical Directors Association, a Florida Society for Post-Acute and Long-Term Care Medicine Journal Club. Today, we have a very special guest, which I will get to in a moment. I want to start with our COVID state of the state. It's been a while since we shared any numbers with you, and I think we're all aware of where we're at as a nation with this virus, over 6.8 million cases in the United States. We're still, unfortunately, leading the world with the number of cases. When we look at global cases, it's over 31.6 million. And we've reached the point of being over 200,000 deaths, which if you've watched any news, you've seen that has been one of the number one headlines. When we look at where we are at across the nation in the state of Florida, our positivity rate, and this comes from Johns Hopkins Resource Center, is at 11.6%, with the United States as a whole being at 5.05%. I know that across the country, there are many places that are in different phases of reopening. I sit in South Florida, and we just entered phase 2 in Broward County this week. So there's a lot of upheaval, a lot of interesting things happening. So if we go to the next slide, it shows really the state of Florida. And I was playing around with a lot of different counties, just looking at Orange County here and just seeing the total cases. The number one county that leads the state of Florida is Miami-Dade with over 167,000 cases. As we know, Florida implemented guidance for testing in the nursing facilities, and that now follows the standards that CMS has. If you go to the next slide for me, Shane, you'll see that when we look at the positive residents and the positive staff as a whole, we've seen that really level off, and the positivity rate for residents is about 1.5%, as that's similar to what it is for the staff. So in our discussions on our board and our task force, just with others throughout our organizations, the question that keeps predominating is, where do we go next? We know that there is an anticipation that we're going to see another surge. In some states, we are seeing that, and in some countries, they're seeing that. We are also very concerned about the flu, and we wanted to have a very open discussion about the next wave of challenges. So to do that, I have asked for Dr. Salman Ashraf to come and speak to us, and he's one of the unique geriatricians who's also infectious disease board certified. And I wanted him to give us his perspective on where we are and to share with us what he has done at the University of Nebraska with the state of Nebraska, because I think we'll all find that very interesting. And Dr. Ashraf, if you would, you could definitely take over and share your slides.
Thank you very much, and good afternoon. I think here is still morning in Nebraska, but I will, like everyone, to know that I really appreciate this invitation, and I'm excited to be talking about this, the work that we have been doing here in Nebraska, and then we'll like to have a good discussion on what the next steps are and where we can go, and how you can learn from our experience, and how I can learn from your experience, and some great discussions. So I will share my screen right now. Okay, here it is. Share screen. I will share this one here. So can you see my slides right now?
Yes, we can.
Okay. And it's not in a speaker mode, correct?
Nope, it is in full presentation mode.
Great. So thank you, Diane. So basically, what I want to talk about a little bit on how state of Nebraska has dealt with the COVID-19 pandemic in post-acute and long-term care setting, and how the partnership between an academic institution with state medical college and the state health department has shaped the response that we have here in Nebraska. And then some unique things that we have done, and then we'll open up to discussion. So probably don't take more than 10, 15 minutes, and then we'll have question answer time after that. So let's go into the next slide here, and I will have to make sure that I'm moving it right. Okay, good. I do have a disclosure. I have received some funding from Mark for one of my long-term care antimicrobial stewardship project. I don't think so anything I will be discussing today has anything to do with that, but just wanted to disclose that. And I want to start with introducing a program called Nebraska ICAP program. What Nebraska ICAP is an entity that was created about 5 years ago with collaboration from the state health department. They have a healthcare associated infection and antimicrobial resistance program at the state health department. Every state have it. Your state have it too. I'm 100% sure about it. So that program that every state have, healthcare associated infection and antimicrobial resistance program, partnered with University of Nebraska Medical Center, which is our state medical college, part of that. And then we have Nebraska Medicine, which is our teaching hospital associated with the medical school. So all three entities came together in a partnership where they said, our state needs infection control expertise available to every single healthcare facility in the state. So some central body that is available to provide assistance and help related to infection prevention and control or antimicrobial stewardship to anyone seeking for that, any healthcare facility seeking for that advice. So that basically was the goal of this partnership that was established in 2015. It started as infection control surveys that we did, non-punitive surveys, just friendly surveys to go and assess infection control policies and procedures and observe infection control practices in these settings. We did those things, and then identify any gaps that facilities may have in infection control, and then provide them the evidence-based recommendation. This is not the same kind of surveys that you will get from CMS that you will end up in citation or something like that. Actually, in our program, we didn't even share the finding with the state. So the ICAP team had the finding, and we only shared de-identified information with the state HAI program. And that was not the licensure division. This is a different division of the state. So we just shared the kind of overall themes with the state, and then we did provide individual improvement feedback to the facility. So and then we drive so many mitigation strategies for the entire state based on the findings that we had. So this program started in 2015. So I just want you to kind of think. So over those 4-year period, we assessed over 150 facilities, included acute care hospital, long-term care facilities, dialysis center, ambulatory surgical center, dental clinic, and even Ebola assessment centers. We did a lot of things for long-term care facilities too. We started a training program for infection preventionists working in this setting with option to receive a certificate of knowledge validation. This is well before the CMS put the mandate for the infection preventionists to be trained. So we already had a program that we were working on before that. Initiated a mentorship program for new or inexperienced long-term care facilities. We assisted healthcare facilities, including post-acute and long-term care facilities, with control of healthcare-associated infection or MDRO's outbreak. We also worked with another program of ours, same kind of infrastructure, just for antimicrobial stewardship. So we call it ASAP instead of ICAP. That's Antimicrobial Stewardship Assessment and Promotion Program, to support the healthcare facilities in strengthening their antibiotic stewardship programs, including the long-term care facilities. And we introduced our new training program for dialysis also last year. So all of this thing was going on pre-COVID in the state for the last 4 or 5 years. And we have created a website with all the resources and tools that we have developed in the 4 or 5 years, and it's freely available to everybody. We developed it for Nebraska, but I think if you guys want to go and look at that website, that's okay too. Then the next step, when COVID-19 pandemic started, we quickly identified that the area that will need the most help will be our post-acute and long-term care setting. And at that point of time, we kind of diverted most of our resources to help post-acute and long-term care setting. Our focus has been all healthcare facilities, but I think in the pandemic, we focused mostly towards the post-acute and long-term care setting. We started our weekly educational webinars in the state even before any single case was identified in long-term care facilities. So we have been having our weekly webinars for 6 months now with our frontline facilities, and almost all of our nursing homes, definitely, and most of our assisted living facilities are on that call on a consistent basis. We bring panelists also from other places, but usually we have mostly state expertise available on that call. We go over updates on those webinars from the last week, and we are doing some assessments as I'm going to talk about that, and we see the lessons learned from those assessments and then bring it back on these webinars and update the facilities on what we have found and how they can fix those problems if they are also seeing those problems. We started our daily office hours. So there are 2 hours in the morning and 2 hours in the evening where our experienced infection preventionists are on the basically standby to take any calls from the facilities, especially mostly the long-term care facilities are the one that calls, and then we provide them the answers for whatever they're looking for in terms of infection control practices implementation. What we do is also called tele-ICAR assessments, where we have worked with the CDC, where they have a survey for infection control best practices to prevent COVID-19 in the facilities, to enter the facilities. So we go with that with the questionnaire with the facilities and make sure that they have all the things in place to prevent COVID-19 into entering the building if the building has not seen COVID-19 cases. For those facilities that actually have seen COVID-19 cases, we do also offer on-site support, meaning that if they are developing a COVID unit within their facility, we have partnered with our bio-containment folks in our hospital, and those colleagues actually go on site and make sure that the COVID unit is being set appropriately and people are following the protocols that are necessary to create such a unit. And they have all the training in place to run a COVID unit. So that is another service that we provide. And then anytime a facility is seeing an outbreak in the state, we pair them. We pair them with an infection preventionist in our program. So a facility infection preventionist and our infection preventionist get paired for the duration of that outbreak. And they have that one-on-one relationship then, that any time that they need a question, they can call them, they can send them email. The guidance is available to them whenever they want based on this relationship. So for the most part, if we are able to contain the facilities, contain the outbreak in the facility, that mentorship relationship doesn't need to last forever. But there has been times where a facility have an outbreak, and then the second outbreak and a third outbreak, and they have found that connection with our infection prevention that they can just keep continuing to work with them as they go forward. So that is another thing that we have been able to do with a centralized program to help all the state post-acute and long-term care facilities. We have developed many different guidance, and this is just an example of one of those guidance that comes out. So for the most part, we do the things uniformly across the state, and part of that is because the ICAP is driving those guidance out, and everybody is working with us on this containment effort. So this is one of those things that we developed back in April, very start of the pandemic, and is still using it, and it still has been our most used, I think, protocols, which is the cohorting guidance to the long-term care facilities. What we end up doing in this guidance is identified 3 zones: red, yellow, and green zones, whenever a facility is seeing a COVID-19 outbreaks, and then having an additional zone called gray zone or transitional zone for facilities that are not having an outbreak, but they are admitting patients from the hospitals and want to have those patients quarantined before moving into general population. So those guidance were put in place. This is just a visual representation of that guidance. That the red zone is our isolation zone, the yellow zone is our quarantine zone, the green zone is our COVID-19 free zones. And then the gray zones are the one that are basically a temporary 14-day quarantine for someone who may have been exposed when they went to the hospital, may not have been. We're not 100% sure about that exposure happened or not, but for the safety purposes, especially in those counties that are seeing high rates, the facility may want to create this zone called a transitional zone where they keep people in for 14 days and then bring them out into the general population. So that's basically how we defined the facilities. Now, there are some slides I have that can go into some detail on what the red zone entails and what the yellow zone entail and what green zone entail. I don't want to take all the time to kind of go over these things, but I will be happy to share these slides later on. And again, the guidance is available on our website on Nebraska ICAP. So that's another place that you may want to go and see all of the work that we have been doing. The final thing I want to add is that, as I said, this relationship was established about 5 years ago, and we have been kind of moving slowly and gradually towards building relationship with all healthcare facilities. And mostly we have worked with the infection preventionist in the facility. So acute care, outpatient, long-term care, wherever we work, we've talked to the people who are primarily responsible for infection prevention work. However, I think we are taking a next step now because we have identified that we need to talk to the frontline staff also. We cannot just talk about infection prevention with the people who are in charge of infection prevention, but with everyone. So we're going to be working with the CDC now. The CDC is working on an education program right now as we speak for frontline staff. So there will be an infection prevention control program for the frontline staff that they are going to be developing a curriculum kind of thing that's going to be optional for the frontline staff to take for all physicians, all nurses, all CNAs, all EVS workers, social workers, occupational therapists, physical therapists, everybody. It will be unique, I think, to the professions. There are going to be certain areas where probably there will be some focus education, but there will be some general areas also. So CDC is working on that, and we will be partnering with the CDC to disseminate that information to the groups when it comes out. So we created this Facebook page very recently to start connecting to the frontline providers and be ready for the time, the next month or two, when the CDC start pushing out those educational material to disseminate it to the providers up front who are working and have that connection right away. So I think what we are encouraging people in our state to have all the healthcare facilities to forward this information to their frontline staff so that they are already following the ICAP Facebook page. So when the information comes along, they can get it right there and then. So that's basically what we are doing in terms of now taking the next steps to bring the infection prevention and control education, not only to the leaders of the facilities, but also to the frontline staff. So I think I will stop here because I want to not take more than 15 minutes and then have some discussion and see where we want to go with this.
Yeah, I thank you for that. I mean, I applaud everything that you guys are doing in Nebraska. I think it's the fact that you had this established before COVID even hit is a testament to how proactive your state is with infection control and prevention. I guess I would like, and if Shane, if you could share our slides again to discuss how you are doing with some of the action items that was proposed in the CMS's commission recommendations, such as reopening and testing and screening. I would really love to hear how you guys were able to, how you guys are doing this.
So I can talk about that. I think what happened was when the reopening guidance initially came along, at that point of time, we decided, based on the resources in the state, we decided that we will go ahead with offering baseline testing before reopening to all nursing home and assisted living facilities in the state. So the state actually provided baseline testing opportunity for every single facility in the state. At that point of time, we did not think that it was possible for us, for the state. When I say us, I'm talking sometimes state and sometimes university. So this time I'm talking about state. The state decides that they will not be able to do the weekly testing at that point of time. But recently with the point of care testing guidance that comes out, I think now we are encouraging facilities to have that. And even for those facilities that have not yet received their point of care testing supplies, or they have run out of their supplies, we are offering at least some support on repeat testing also for our facilities. So for example, for those counties that are called red counties, instead of having PCR testing available to them on a 2 times a week basis, the state is at least providing them once a week services. So if they have supplies, point of care testing, they are encouraged to use it 2 times a week as the CMS guidance dictate. But if they cannot get that, at least they can get it once a week through the state. Same way with the yellow counties. If they cannot get it weekly, they can get it every 2 weeks at least. Basically, there is an option available for them if they run out of their supply or something like that. They can rely on the state to provide some support on that. So that's testing. That's testing part. But we did also put guidance on visitations and communal dining and all those kind of things. And we have it called like phasing guidance. So phase 1, phase 2, and phase 3, the facilities were supposed to do their baseline testing before entering into phase 3, but they can move from phase 1 to phase 2 before doing the testing. They were allowed to move from phase 1 to phase 2, and mostly those phasings were supposed to be in coordination with their local communities. So the local community moving through phases, they can move through phases also. So that's how we implemented the guidance. Now with the recent guidance that comes out on visitation from the CMS in the last few days, I think that will supersede our previously existing visitation guidance, and we'll follow the CMS guidance in our state also for visitation. So we this week we have been talking to the facilities about the new visitation guidance and how to implement that. In terms of PPEs, the state is actually helping facilities out with the PPE also. So they have about a large amount of supply at the state level, and facilities can access to it by putting a request in, and they have to be reasonable request, definitely. But if they are having an outbreak and they are requiring a large number of gowns and gloves and things like that, our state has been able to help them with that increased demand so far, and some of that is being kind of controlled through ICAP itself. So basically what it is that because every single facility that is having an outbreak, even a single case that's called an outbreak, right? Every single facilities who have a case, ICAP provide assistance to that facility. So we become like a gatekeeper, and we can tell the state that this facility really have a problem and they need the gowns and gloves and things like that. And they do listen to us and provide. Same thing with the testing. If they are having outbreaks and they need testing, ICAP has been helping them get testing done. Now, up until recently, the testing guidance was not as clear as you go ahead and do the entire testing of the entire building. Even for assisted living facility, is still not that right now. That the guidance, the CMS recommendation mandate is for the nursing homes and not really the assisted living facilities. So we have been, where necessary, we have been doing the testing based on the exposure area. Basically, we identify an exposure area. We have a guidance document on our website on that also, on how to kind of identify which areas need to be tested in the building and things like that. So we have been helping facilities. And then we talk to them, we identify the exposure, we identify who needs to be tested, and then we tell the state or local health department that this facility needs to get these number of tests done in the next week or two or whatever, and they supply them the test kits to get them done. So state takes care of all the outbreak testing.
Wow. Yeah, and to those who've asked this question, we will have, if it's not already in our COVID library, we will have the CMS commission report and the latest reopening guidance posted there. I do have a question as we're thinking about what's next. A lot of reopening, a lot of our state is moving into phase 2, if not already at phase 3, and then we're seeing that as a whole with the country. When we think of hyperlocal events and then things that could happen with our nursing facilities, the greatest challenge comes around the flu prevention and thinking about those types of outbreaks. What are you doing in Nebraska that we can learn from in regards to preparing for both the flu and COVID at the same time?
Yeah, so the basic steps are the same, correct? I think we probably are at lower risk of introducing flu this year than probably we were at last year in our building, just because not only we're doing the heightened screening, we are also wearing masks, and in some counties also eye protection, correct? So we are in much more protected environment today than we were in the last year. So I'm hoping that flu probably will have much less impact this year than last year in our building, but we cannot take it for granted. I think we have to still continue to focus on our screening, on education, social distancing measures, and plus vaccination. So as we should start the vaccination as soon as the vaccination becomes available for our elderly population. so that they are protected. But I think all the other things will still be in place. The Tamiflu prophylaxis, that will still be in place. Now, the difference that I see from the last year to this year, how do you perform flu vaccination in your facility may have to be looked into carefully. Is that what is your procedure of performing the flu vaccine? What we don't want is situations where there are lines in the building where you're giving flu, or you establish a flu clinic for your staff, and they are just kind of standing in lines to get those flu vaccination. I think you may want to think about more of schedules visit rather than just come in at this time and have a line and we'll get everybody tested. So I think having a big enough space where you can social distance and can safely administer the vaccine, not keeping anybody longer than they need to be in the flu vaccine area, and also having everybody wearing the mask while they are there. So all of those things have to be in place. So how do we administer the flu vaccine is going to be always a question that we'll have to, the protocols we have to review for that. And that's basically how I see a difference between the last year and this year. But if we are following our protocols for COVID-19, meaning the screening, social distancing, mask wearing, all those protocols we are following, I think we are already working on both flu and COVID.
Okay, thank you. And I guess the question that is still at the front of my mind or top of mind is, what do we need to do to evolve our infection control policies? In thinking about some of the highlights from the CMS Commission report and some other literature that has hit the geriatric journals and JAMDA and all of those things. The question is, where have we fallen short, or where do we need to go from here? So I would love to have your perspective in thinking about creating infection control policies for nursing facilities and assisted living facilities.
So I think what it has done, what COVID-19 has done, is that kind of expose some of the biggest vulnerabilities in our setting, correct? I think we just have to have a different mindset going forward in terms of how we will approach these situations. I think infection prevention and control training will be the front line measure that we have to take in terms of going forward. I know that everybody was working, at least some, on infection prevention and control training, but we also know that the PPE was not that much ingrained into our DNA. How many of us had in the long-term care setting fit testing before this, correct? So some of those infection control precautions that were not ingrained in our DNA in the post-acute and long-term care setting, I think that will have to change. I think we were also discussing, I know that in the last couple of years we have been discussing about what's the role of the infection prevention, how much time does the infection preventionist need, and maybe the facility have to do their own infection control risk assessment and come up with a time. And so often than not, I used to see that facilities' own risk assessment find a time that they thought will be good for the nursing homes for their infection prevention control effort, but probably far from what they needed, far less from what they needed. And I think the pandemic has said that this is probably a position that we have to put much funding in. Rather than appointing a 0.2 FTE or 0.1 FTE, I think this is not that kind of a position that somebody can just do a part-time and go by. So some of those type of things have to be changed. So the frontline training, the infection preventionist position needs to be updated. And I know the training was already going on. We were already talking about the training, but this is just a next level. Not only training, but giving them enough resources and opportunities to implement those the things that they learn in the training. That was not there. Infrastructure, we never think about airflow in the nursing home. Where how is our air flowing into the nursing home? If we need to ever change the airflow into negative pressure or something like that, in the hospital we have been doing that. That wherever we need some negative, on the go we can develop some negative areas, and things like that. And we have done it this time around in some nursing homes also. We have been able to. There have been some nursing homes in our state where we help them develop some negative airflow on the go. As a temporary basis, so that they can house COVID-19 things. So facilities can even start to plan for those kind of things. If we ever need to go into an emergency mode where we need negative airflow, how can we look into our building and see that can we develop that, or can we make some modification that allows us to do that? So some of those infrastructure thing that we probably cannot change all our buildings, but wherever we can have opportunities to, if we are building new areas, new units, things like that, on how to account for shared bathrooms and things like that. What can we do about that? I think all those infrastructures have to be looked into, because it's not just the COVID-19. So when we started our program in 2015, it was in response to Ebola. Mm-hmm. And when we was putting it together, we knew the Ebola is going away, or probably going to go away. But we were looking for having infection control expertise for the rest of the healthcare facilities that Ebola didn't affect, but we knew that something can come along and can do that. And I think that's the mentality we have to take from now on. But it's not about COVID-19 now. It's about what next thing arrives and are we going to be ready for that. So those are just some thoughts that I put down here that we have to start kind of brainstorming. I don't have all the answers today, but I know that we have been learning lessons that we can apply as we go forward. Developing COVID units in a facility, we have been getting better and better in doing that, at least in our state now. The question is that can we be in an ever-ready state where if we have to turn something very quickly into a biocontainment area in our nursing home, can we do that? Now, it's not easy. I'm not saying it's easy. I'm just saying this is just a thought process. Where are we going? And definitely all of this will require significant amount of expenses. So I think we will probably, it has to be some federal funding that has to come in for all of this to happen. What I'm saying, I think I'm saying it all, big things here and big thinking, but I know that that's not going to happen unless there is some really good support out there.
Yeah, and I agree with you. I think we're going to have to challenge ourselves and expand our imagination about what we need post-acute long-term care to be. And the infrastructure, not even from how the building is set up, but, staffing, the guidance. I think you're right that this has shown all of our vulnerabilities, and we need to get prepared and think about what we need to do. And I liken it to, Florida, we've seen many disasters secondary to our weather and the hurricanes. And this is a different type of disaster, but with an even more profound impact. And I think that in thinking how we keep staff safe and how we keep residents safe, we need to just rethink the way we do everything. And with that, we did have a question that came up in the chat about flu vaccinations and whether we should have one now if it's available or wait till later so that the immune response lasts later to spring. What is your thoughts around that?
Yeah, I think we're late enough now that we can go ahead and start. Definitely, CDC doesn't want us to give the vaccination in August, but now I think late September and coming into an October. This is good enough for us to start the vaccination. So once you have your vaccine, we can go ahead and start now.
And someone else asked a question about whether we need 2 flu shots this year or in this time period. Would you still recommending the solo flu vaccination?
That's what it is, the recommendation from the CDC, and I'll stick to that.
And do we have any other questions? Well, if not, I do thank you, Dr. Ashraf. I thank you for your guidance and the information that you're providing. Florida, we have a lot of experience in post-acute and long-term care. I don't know, and this is just my own personal opinion, I don't think we've had the organization that you've seen in Nebraska, and we're still trying to improve upon that within our organization. I thank you for your time here. And if we have any other questions that come in later, as they do, we will definitely shoot them over to you. I thank you.
No problem. Thank you very much. Thank you for allowing me to be part of this discussion. Thank you.
Thank you, everyone.